Good morning. My name is Tamsin Ford. I am Professor of Child and Adolescent Psychiatry at the University of Cambridge. And I'm here to talk to you a little bit today about the first of three planned follow-ups of the 2017 English National Survey. So for those of you who aren't focused on the mental health of children and young people, although it's great to see a session on data linkage in young people who often get neglected, I just want to set the scene. There have been fewer surveys of children. Children were quite far down the list in terms of the surveys that the Department of Health ran in the late 1990s. So our first survey, you can see from this graph in front of you, was in 1999. There was a fourth one in 2004 and a final one in 2017 with a very big gap. The adults have been surveyed every 7 years, but I guess 5 years on from 2009 or even 2000, even 7 years, 2010, I don't think the government wanted the news. Also, it was in the depth of a financial crisis, and I think, quite frankly, they hadn't got the money. What you can see here rather undermines the screaming headlines that we've had for several years now about an epidemic of poor mental health amongst children and young people. There has been a decline, and it is statistically significant from 1999 at least, and it's there in both girls and boys, but it wasn't quite the dramatic increase that we all expected to see. Again, for those of you who don't work with children and young people, this shows that the prevalence of mental health conditions increases by age. I should say this was a single phase survey in a large probability sample, so just over 9,500 children in total. If you look back at the first slide, it's this rather odd 5 to 15-year-old age group, because that was the age group in the original survey. So in order to compare, we had to stick to that. But in fact, this most recent survey in 2017 is exciting because it went down to the age of 2. It also showed some overlap with the adult surveys, because we are a profession that's separated by a common language, and those of us who work with adults and those of us who work with children diverge in our trainings very early on. Our measures differ, and I think we quite often use different words to describe the same phenomenon, or even the same words when we mean different things. So having that overlap in the older age group is also really good. Every single parent, all young people aged over 11, and if the family agreed, the teacher, were invited to complete a measure called the Development and Wellbeing Assessment, which is a multi-informant standardized diagnostic assessment. And so when I'm talking about mental health conditions or disorders, I mean DSM-5 or ICD-10 diagnoses. Because I've borrowed the slides from NHS Digital, these will be ICD-10, but the data set includes both. And one of the things that emerged was a rapid acceleration of emotional disorders, so both anxiety and depression, in older teenagers, and particularly among young women, which had also been seen for the first time in the previous adult survey, which of course starts at age 16. So the point I'm trying to make is the pandemic hit at a time where we had fairly convincing evidence and increasing evidence of deteriorating mental health amongst our population of young people anyway. And then earlier this year, this very important paper, which compared outcomes in adolescence in relation to attainment, health, social care, things like having a conviction or a caution, between those born in the 1970 birth cohort, Ausbach, which were all born around in the early 1990s, and also the Millennium cohort, and demonstrated for those who were born in the current century, there was a worse outcome. So we have a double whammy at the moment of deteriorating mental health even if funding wasn't reduced for child mental health services, a lot of other services in the voluntary sector and in schools that had been providing mental health support had their budgets cut and withdrew. So you got increasing demand, less ability to meet it, and perhaps also worse outcomes. Final point in setting the scenes, what you're looking at here is the reports from 2004 on the Selfreport Strengths and Difficulties Questionnaire, which is a brief mental health general distress measure for children and young people, the parent responses on the same children, and the teacher responses. Now, the fact the graphs are such different shapes are fascinating because the only difference between the parent and the teacher one is a P or a T in the top left-hand corner. But it's also to give the point that our diagnoses are mostly cut points on a continuum, and the psychological resources and social support of the child will determine a little bit where those cut points are on the borderline, but that there isn't a sharp distinction. So for every one of those young people who were struggling, according to the diagnostic assessment, there are probably several others who are bubbling just under. I will show you in a second just how much low quality information there is around mental health. The word unprecedented has been used so many times in relation to COVID-19, it's almost meaningless now. But there really has been an unprecedented epidemic of rapid research. I guess we have a real data gap in relation to children, and some data, arguably, I would say, is better than no data, and you can get out into the field much quicker, often with a Qualtrics or a SurveyMonkey online. But the problem with these fast and quick surveys is the responders are often affluent, educated, white. They're not necessarily typical of the population. Bigger does not get rid of bias. I'm sure I'm teaching my grandmothers to suck eggs here. So, for example, a paper out of China, which has a gender ratio skewed towards men because of the one-child policy, a paper was reported to have 52,000 participants, but that doesn't make it great in terms of representativeness when it had 65% women. It's important to be aware that weighting only partially addresses such biases, and most of our statistics are based on having a probability sample. So you can't really be sure of the precision if you don't have a sample frame. Some of you may be aware of this absolutely heroic systematic review. Now, I last checked it last week, so these figures were up to date as of Monday of last week. They have screened over 33,000 abstracts since registering this review, which is a combination of 3 reviews, changes in mental health for which they require a defined population frame and pre-COVID data, factors associated with changes which they've now stopped because they feel they've got data saturation, and they're also getting intervention studies related to mental health in COVID. So 33,000 abstracts, of which 19 met sufficient quality for inclusion in review 1. There's a lot of noise out there. So now on to the meat of my talk, which is about the follow-up of our national survey. So this was commissioned by the Department of Health and Social Care with input from the Department for Education, the Children's Commissioner, and many other relevant third sector organisations. It therefore provides official statistics into child mental health. And despite our best efforts, it took till July to get into the field. So everybody from the original survey who had given permission to be contacted and for whom we had a viable contact email or telephone number was invited to be part of this survey. That number was sort of between 7,000 and 8,000, And actually, I'm both relieved and frustrated by the response rate, which was 45%. I'm relieved because despite a lot of nagging in the original commission to do a follow-up, there has been absolutely no keeping in touch with this cohort, and it could have been a lot worse. I'm frustrated because of the fact that we could have done so much better if we tried to keep them together. So it was an online survey of parents, for those who were, by the time we went back, 5 to 16, separate questionnaire for children if they were aged 11 to 16, and then young people aged 17 to 22 had a slightly more complicated survey than the younger teenagers. And we had two aims. One was to compare the mental health as two separate cross-sectional samples, because we only have 2 data points and you can always draw a straight line between 2 data points. And we were being pulled all over the place by policy demands, so we haven't had much time to go back and do anything else. And also to get some sense about what life was like during the pandemic. Now, obviously, I don't have much time, so this is going to be a quick sprint through what we know and can do. There's much else to be done. One important thing to grasp is we obviously couldn't go out and do the developmental and wellbeing assessment all over the country again. So we used the strengths and difficulties questionnaire, which we had in 2017. So when I talk about a probable mental health condition, it is using this algorithm, which you can download the code for from the website on the slide, which will combine data from 3 informants if you have them, but will work with only one, and uses an algorithm to split your sample into unlikely, possible, and probable to have a mental health condition. And this has been validated against the very first national survey. So if you're unlikely to have a disorder, less than a fraction of a percent went on to be picked up by the DORBA as having a mental health condition. In a general population sample, depending on the type of condition, it's about 2/3 have a probable mental health condition. So the bottom line, has there been a further deterioration? Well, yes, there has. So using the DORBA, we had 1 in 8 children had a psychiatric disorder. Using the SDQ in 2017, it's 1 in 9. So it's not actually that different. And also the SDQ seems to be underestimating a bit, which is important because in 2020, it was 1 in 6 children. So in your average class of 30 children, that is going to be 6 of them, 5 of them with a disorder. Again, young women had experienced the same deterioration. Amongst the older teenagers, it was about 1/5, and that has come out of other studies like the UK longitudinal survey data, led by Matthew Pearce from Manchester, and published in Lancet Psychiatry. And again, young women seem particularly vulnerable, with over 1/4 of them appearing to have a mental health condition. We asked on a simple Likert scale whether how lockdown had affected young people's lives. And 40% of 11 to 16-year-olds, and a little bit higher number of young people who in the general population felt that lockdown had made their life worse. It won't surprise anybody amongst those likely to have a disorder, this was a higher number. As well as the survey, we are just about to start some semi-structured interviews where we will sample young people according to how they responded to this question, to talk about what were the issues that seemed to either make things better or make things worse, because it would be useful to know what are the things that are positive as well as the negatives in order to mitigate future lockdowns should we have to. High numbers of people reported sleep problems in the general population, and again, you know, this is correlation, not causation, and the relationship could work either way. More likely to occur in people who had a disorder. Again, another important risk factor, particularly for depression. 1 in 10 children and young people in the population reported always or often feeling lonely. And again, this was much higher amongst those with a probable disorder, and also amongst young women. We asked about help seeking, and as other people have reported, a lot of people reported delaying seeking help for both physical and mental health concerns because of the pandemic, which is very worrying. And you know, we somehow need to let the population know that actually services are not closed. So the data on the slide relate to children and young people, but we had the same report from parents about this with very similar figures. We are also doing a series of qualitative semi-structured interviews around service use, and this is one of the things we want to unpick in a bit more details, because if we understand better why people are worried, then we can, if possible and appropriate, offer reassurance. So what should we do? I think from the evidence that we found in the survey, I haven't presented it, but those with disorder reported much less support from school. Now, whether that relates to not being able to engage in support that's offered, or whether it's because the risk factors for poor mental health cluster with risk factors for difficulty in accessing high quality education, I don't know, but there is accruing evidence that actually the best place for children to be, if at all possible, is school. And I think it's a shocking indictment of our society that we reopened the pubs and the restaurants before we opened schools. Given the dismantling of safeguards around children and young people, and the fact that many of the most vulnerable are still out of school and just dropped off people's radars, we need regional and local multi-agency planning. And actually there was evidence that firstly, it's easier to get multi-agency panels together and to have conversations when you don't have to travel to do it. So that has been one positive. But also that people saw the danger and were working very hard across agency boundaries to try and do the best they could for these vulnerable children they were aware of. Of course, with more families under pressure and more parents with mental health and substance misuse problems and more children struggling to cope, the risks extend to families that we may not know about yet. Services have had to pivot to delivering remote mental health care, and their activity level hasn't dropped. It's just new referrals have dropped, although I believe they're picking up again. And there has been a reluctance to embrace remote ways of working for mental health, and I'm not denying that there are considerations around safeguarding, confidentiality, all that kind of thing. But actually, I think the experience has not been universally negative. And in fact, for many families and clinicians, it's been quite positive. And so I think it's important we don't just throw out the baby with the bathwater when hopefully next year things return a bit more to normality. And it would be fabulous to co-produce guidelines for how best to use remote ways of working and for whom it is appropriate and effective. And this group won't need convincing that the use of routine data to support services is really important. The vulnerable groups seem to be those with pre-existing mental health conditions, and there's some interesting work from the School of Public Health which may underline those in our sample who said lockdown had made their lives better, which showed that children with anxiety or depression above cut point in October actually were scoring better when they went back to them in the spring. And that may be about reduced pressure because of being out of school, or reduced bullying. We shouldn't forget that some children will have had some very adverse experiences during lockdown, and those with special educational needs and disability are not receiving support. Many of the families just had their respite care cut. It's been a really tough time for families. And so we need to get innovative about how we can support families. And I will make the slides available. I just wanted to highlight this really innovative work by Helen Minnis and colleagues in Glasgow, where they demonstrated actually diverging experiences within families, depending very much on health and wealth. Those who had the resources to work from home and for their children to access education, actually within a couple of months were valuing the time together, managing to cope, and things had kind of settled down. Initial anxieties had subsided. But actually, for other families where there was housing or financial insecurity, where there wasn't access to Wi-Fi or not enough devices to go around for all the children in the family to be able to access school and for parents to work, things were getting much tougher, and they were seeing the uptick in domestic violence that we all worried about. So ideally, all children should be in school, but if infection rates rise too far, that becomes untenable. Well, then perhaps we can have bubbles, which some schools have been operating, where you try and keep children together in the same bubble, and at least some of them are in some of the time. And then if the infection rate is too high, can you not have some kind of child clusters that allow a degree of social interaction, but also respite for parents? So one of the foci of today's meeting is thinking about data linkage. And of course, I've talked about primary research. I think there was consent sought and given by most people to link their data to health and to the National Pupil Data Set in 2017, and it's never been done. We have reconsented those that we've contacted, and we're pushing really hard to try and make this happen, because that would allow us to look back at patterns of, say, attendance at school, at characteristics of attending at services or not, for those who seem to be doing badly now, which might help us target a response. I think finally, just to think about how we put all this into practice to help children. All of us have positive and negative influences on our mental health, and in children in the school context, it often comes out as behaviour, which can be positive and negative. And we hope that most of us hover around this quadrant. But of course, there will be more children and more families where there are negative impacts and perhaps negative influences, and they're drifting into more difficult behaviour or struggling to concentrate at school, etc. I just wanted to highlight there is a systematic review of the evidence behind what teachers and school staff can do. It's actually based on 3 systematic reviews with some very brief guidelines for practitioners. And that schools really need to try and focus on what they can influence directly. There are other things that are useful to be aware of, but it's much harder to change. But these are the things that the school can do that can make a difference. So most children are still doing fine. Although the number of children with probable mental health conditions has increased, most children are doing okay. There will always be a clinical population, and the sense is it may have got a little bit bigger, but the group that I'm worried about is this vulnerable group. And those of us who work with a sort of more public health eye need to be thinking of ways in which we can try and push the risks for this vulnerable group down so that they can carry on developing. I've put in some resources and some references, and I look forward to meeting you on the panel. Thank you.